Good morning, good afternoon, good evening. You are listening to the Revolution Health Radio Show. I'm your host, Steve Wright, co-author at scdlifestyle.com. This episode of Revolution Health Radio is brought to you by 144.me. 144.me is your healthy lifestyle reset program. So I don't know if you're like me, but you're probably going home for the holidays. You might lose some sleep due to travel. You might indulge in some sweets because it's sweet and they taste great. And you might fall off your exercise routine because you don't have availability to gyms and trainers and things like that while you're back home. And what I want to let you know is that Kresser has put together 144.me for all these types of scenarios, and just for everybody else who's looking for a reset for their life, if they're just not feeling the way they want to feel, if they're still having some digestion issues, some sleep issues, some energy problems, 144.me will be your solution. It's a step-by-step program that walks you through stress reduction, diet enhancement, movement, as well as sleep. And all four of those things are the key to having a great life. So
maybe you need some more sleep, Steve.
I might need more sleep. Anyways, 144.me, check it out. That's what this show is all about. Just kidding. With me is integrative medical practitioner, healthy skeptic, and New York Times bestseller, Chris Kresser. Chris, take it away, man. I need to stop talking.
All right. Yeah, so we've got a great show today. Good question. And I'm just hunkering down for this storm that's coming in. We were warned to stock up on some water and do almost like earthquake prep because there's apparently a crazy storm coming that might knock out power and
really
and wreak some havoc around here.
Is it like an Arctic blast or what?
I don't know. It's supposed to be just a crazy heavy rainstorm, like 2 to 3 inches of rain in a short period of time. So we'll see. Sometimes they warn about these things and they never really materialize, but it should be interesting.
Hey, go with the Boy Scout model. Better be safe than sorry.
That's right. So let's dive in. I know you're going to ask me what I had for breakfast, and that won't take long because it was this is my breakfast right here, just coffee and cream this morning. Intermittent fast day. So that's it. Nothing too exciting.
Well, you know what? When the storms are brewing, you got to simplify life, so I get
it. That's right. All right, so this question is from Isabel, and let's give it a listen.
Hi, Chris. Thanks for your podcast. I'm a female 44-year-old and recently discovered that I had a SNP that predicts high LPA levels. So I measured my LPA, and it's at 92 milligram per deciliter, while otherwise my LDL is at 110, HDL 75, and I have low triglyceride. My doctor wants me to take a statin and baby aspirin to lower my cardiovascular disease risk. I already know that there are some alternatives to baby aspirin from your podcast, but should I really go for the statin to reduce it between 40 to 70 milligram per deciliter? What do you think? Thank you very much again for your podcast.
Okay, thanks Isabel for your question, and please do keep the questions coming, people. As you have no doubt noted, that's the new format for the show. I guess it's not that new now, but this is all listener question driven. So please do keep sending us your question. What's the link, Steve?
chriskresser.com/podcast.
Right. So head over there and record your question. Helps us to make sure that the show is relevant to your interests and what you want to hear about. So anyhow, lipoprotein little a, we're going to call it LPA, so I don't have to say that throughout this whole episode, and that's often what it's referred to anyways. LPA is an LDL. It consists of an LDL particle which contains an apolipoprotein B molecule linked to another apoprotein molecule called ApoA. So that's quite a mouthful. Essentially, it's a small, dense, highly inflammatory lipoprotein. That's really kind of the takeaway and what you need to know about it. And LPA levels are strongly influenced by genetics. That's probably the number one factor that influences their level, unlike some other lipoproteins like LDL and HDL, which are pretty heavily influenced by diet and exercise and lifestyle. LPA I think it can be affected by those things, but not nearly to the extent that LDL and HDL and total cholesterol are affected.
So just for those listeners who haven't gone back and reviewed, Healthy Cholesterol Action Plan or the rest of the podcast about this, HDL, LDL, and LPA are all separate types of lipoproteins, or does LPA stack underneath one of those?
It's LPA is more related to LDL because it's an LDL particle that contains apolipoprotein B linked to ApoA. So it's a subclass of LDL.
Okay.
But it's a more atherogenic form of LDL. So it means it's a type of LDL that is linked to a higher risk of heart disease, much more so than LDL itself. And the production of LPA is controlled by a specific gene. So if you have a mutated version of that gene, then it can lead to higher LPA levels. And this is more common in African Americans and less common in Caucasians. There are other kind of genetic relationships, but what I'm trying to say here is that LPA is pretty strongly genetically determined. So you could be doing everything right, frustratingly, and still have a relatively high LPA level. And the thing to understand is that LPA in studies has been associated with higher risk of cardiovascular disease and heart attack, and it's been validated as an independent risk factor for heart disease, meaning your other risk factors can be normal, but if LPA is high, your risk for heart disease will be higher than if LPA wasn't high. Now, I'll come back to that at the end because calculating or figuring out your overall risk for heart disease is pretty complicated, and you can never just do it based on one marker. But the point is that LPA is an independent risk factor for heart disease. And the reason that's the case is that LPA, it collects in the arterial wall, and it's thought to be involved in clotting. So it can increase the probability of endothelial damage because of that, and because it's so small and dense, it kind of penetrates the fragile lining of the endothelium, which is the lining of the blood vessel. It's thought to play a role in the rupture of plaque, which is the initiating event in a heart attack. And it also is thought to carry a significant amount of oxidized fat, so oxidized LDL, which is, as you know, if you've been following my work or listening to the show, oxidized fats are much more atherogenic than non-oxidized fats. So LPA is not a good guy, it's a bad guy overall. And
well, it probably has some good functions, right? We just want it at a certain level.
Yeah, it's really interesting. Linus Pauling had a pretty interesting theory about LPA. It's only really found in mammals that don't synthesize vitamin C endogenously. Most animals make their own vitamin C, but primates like humans and monkeys we don't make our own vitamin C anymore. That's why we have to get it through the diet, and if we don't get it, we get diseases like scurvy. And the only animals that produce LPA are the animals that don't produce vitamin C. And vitamin C plays a role in collagen formation and clotting, and so does LPA. So Linus Pauling developed the hypothesis that LPA acts as like a surrogate for vitamin C. And especially when vitamin C levels are low or there's a deficiency of vitamin C, the liver will make more LPA as a way of performing the functions that vitamin C would otherwise perform, like clotting and collagen formation, etc. So it does definitely play some potentially useful roles, as you pointed out, Steve, but just like LDL cholesterol does. But it's one of those things where too much of a good thing ends up being a bad thing. So there are a lot of things to consider when we talk about LPA, and we're going to go through those here, and then at the end we'll kind of summarize and talk about the overall picture. So the first thing is that you have to get the right measurement of LPA. So Isabel gave us her measurement in milligrams per deciliter. I think she said her level was 92 milligrams per deciliter. The problem with milligrams per deciliter as a measurement for LPA is that it's a weight-based measurement. So like other lipoproteins, you can have smaller, denser LPA, or you can have larger, more buoyant LPA. And the larger, more buoyant LPA will weigh more, but they don't have the same, they're not as harmful as the smaller, denser LPA. So in order to get a measurement of LPA that's not affected by weight, you need to measure it in nanomoles per liter. N as in Nancy, M as in Mary, OL/L. And that's thought to be a more accurate indicator of LPA mediated risk, is measuring it there. And I've seen some people with a relatively high LPA in terms of milligrams per deciliter, but a normal LPA in terms of nanomoles per liter, and those people would not be at increased risk. So that's important to do, especially if you have a profile where you have large buoyant LDL particles, because you'd be more likely to have higher milligrams per deciliter measure of LPA, but maybe not high in terms of nanomoles per liter. So that's number one. Just so you know, the ranges for LPA in nanomoles per liter would be ideal would be below 35 nanomoles per liter. Borderline would be 35 to 75. High would be 75 to 125, and very high would be over 125. So that's number one. Number two is LPA is a risk factor, as I mentioned, and it is independent of other risk factors, but you really have to consider the overall picture when it comes to heart disease. It doesn't occur in isolation, and when we talk about heart disease, we're talking about people, not just markers. So a 44-year-old woman with no other risk factors and high LPA is still likely at relatively low risk for heart disease over the next 10 to 20 years. Now that doesn't mean you should ignore this and not do what you can to address it, but it does bring into question what is the value of taking a statin drug for a 44-year-old woman, because studies have shown that for women who don't have pre-existing heart disease, statins do not extend lifespan. So that would suggest that even if a statin did lower LPA for a woman without heart disease, it wouldn't necessarily prevent death from a heart attack or extend her lifespan in any way. So for me, that's a big question mark then in terms of the value of taking a statin in that situation. Third, and this is related to what I was just talking about, the evidence that lowering LPA actually reduces heart disease risk is pretty weak. So we know that high LPA is associated with heart disease, but studies that have looked at lowering LPA with medications have not found that heart disease risk necessarily goes down when you do that. And what's interesting is that's actually true with HDL cholesterol as well, which is the good cholesterol. We know that high HDL levels are associated with better outcomes, but when you look at studies where they use drugs or to increase HDL, the people don't necessarily have a lower risk of heart disease as a result. And that comes back to that we have to look at the person and not just the markers. If you do some kind of drug intervention that just gooses a marker higher without addressing any of the other diet and lifestyle factors that led to that marker being low in the first place, then that's not really a fix that's going to work well over the long term. So there may be something similar with LPA, and we need more research to figure that out.
Yeah, you're tracking biomarkers that we haven't confirmed actually do or don't do
That's right. I
things.
mean,
The real event is heart
we
disease.
there's a lot of questions about, so why is, we see that LPA is higher in people who have heart attacks, but does that mean that LPA is causing the heart attack? Or maybe LPA is being produced at higher levels because there's some underlying damage to the tissue that is causing both the heart attack and the LPA to be high. And so this is why it's so important to be careful with observational research, and not only focus on markers, to look at the bigger overall picture. So number 4 is that despite, if you research online, you look into LPA, you'll see claims that diet and lifestyle just absolutely have no impact on LPA levels. But that's not actually what I've seen in my work with patients, and I know from talking to other clinicians that they feel the same way. There is some anecdotal clinical evidence that LPA responds to some natural treatment. So I've seen, when people add, if they're not getting enough omega-3, long-chain omega-3 fats like DHA and EPA, if they add those to their diet, I've seen LPA levels go down. I've seen LPA levels respond to switch from like a standard American or not very healthy diet to a paleo type of diet. I mean, if you think about it, an LPA is there to repair damage, and we're following a lifestyle that's causing endothelial damage, then it makes sense that changing diet could potentially influence it. Then we have studies that have looked at some natural treatments and found that they've been effective to greater or lesser degrees. So, for example, a study in 1998 found that taking 2,000 milligrams of niacin hexanosinate, which is a time-release form of niacin, which is vitamin B3, for 96 weeks. So that's a long time. This was not an overnight
Almost 2
effect.
years.
Yeah, lowered LPA by 39%. So that's a pretty significant decrease. That could definitely drop you from being in the high risk category into being in the normal or slightly elevated category. That's a big dose of niacin, and as many people know, that high of a dose of niacin can cause flushing. So it's probably a good idea to do that under some kind of medical supervision.
Yeah, and if you haven't flushed before, you'll want somebody there.
You'll not like it. Yeah, you will want somebody there. Another study found that 2 grams per day of L-carnitine, an amino acid, lowered LPA levels by about 20% after 6 months. And then finally, the clinical evidence has not really been that supportive of this, but as I said before, Linus Pauling hypothesized that vitamin C, that LPA might be a surrogate for vitamin C, and he did some additional studies that found that in animals that found that when vitamin C was low, LPA levels were higher, and there was higher risk for heart disease. So supplementing with vitamin C along with L-lysine and L-proline, which also play a similar role, may lower LPA. I do want to point out that some of the studies that have been done using somewhat lower doses of vitamin C than he recommended, Pauling recommended, so they use like a gram or 2 grams per day of vitamin C, whereas many people who recommend this treatment, including me, use more like 3 to 5 grams of vitamin C along with 3 to 5 grams of both lysine and proline per day. I have some patients that I've used this in. I think it's safe. Vitamin C is non-toxic even at high doses, so there's very little reason not to try this. So I start patients with 1 or 2, a lower dose, like 1 gram of lysine, proline, and vitamin C per day, and then have them gradually build up to 3 to 5 grams per day of each. Use, with divided doses, not all at once, so it reduces the likelihood of any kind of adverse
Yeah, with
effect.
vitamin C there that you're using, is a special kind, like lipo?
Liposomal is better absorbed, but that can get pretty expensive at 5 grams per day. So I think, like an ascorbic acid can work, or a buffered form of vitamin C if you have gut sensitivities to it. So any depending on what you can afford and what makes sense, either one of those should work. So if you add B3 and you do carnitine and you do the lysine, proline, and vitamin C, and you put all of those together, in most cases we do see a decrease in LPA over time. A fourth thing that I've seen some suggest, but I haven't done so much myself, is lumbrokinase, which is an enzyme that assists in the breakdown of fibrin, which is a protein that's involved in blood clotting, which LPA plays a role in. So the lumbrokinase, some other practitioners have used it with some success to lower LPA levels. Delta and gamma tocotrienols, which are a different isomer of vitamin E. Most people when they take vitamin E, they take alpha tocopherol. Tocotrienols are another form of vitamin E, and they have been shown to be effective in lowering LDL particle number and LDL and total cholesterol. I don't know if they lower LPA, but it's probably worth a try because, again, it's safe. 200 milligrams of the tocotrienols are safe and effective treatment for lowering LDL particle number, and since LPA is a subfraction of LDL particles, it makes sense that might work too. So as always, don't consider this medical advice. Check with your doctor before doing any of this stuff, but all of the things that I've recommended, ranging from a paleo, nutrient-dense, low-toxin diet to increasing your intake of long-chain omega-3 fats, to the niacin, L-carnitine, lysine, proline, and vitamin C, and the lumbrokinase, and the tocotrienols are all, safe interventions that, with the exception of niacin, which can cause flushing and should be done under supervision, I would consider to be much safer than a statin drug, for example, which is often what's prescribed in the case of high LPA. So,
are there some other markers, Chris, that people who are thinking about this should look at? Because, on many other podcasts, we've talked about the fact that essentially we're looking at hired inflammation. The arteries are getting damaged somehow. And we've also linked this in other podcasts to leaky gut and other things. But as far as biomarkers go, if someone's going to go back and retest their LPA to get the nanomole per liter, should they ask for HSCRP or something else?
Yeah, you should be. Yeah, CRP would be helpful. LDL particle number, the NMR profile that we've talked about before, where you're measuring the actual number of lipoproteins instead of the amount of cholesterol that's inside of the lipoproteins. Doing a gut, as you pointed out, Steve, gut profile. You want to be looking for anything that could cause a chronic inflammatory response. So that could be SIBO, bacterial dysbiosis, fungal overgrowth, parasites, intestinal permeability. There's a lot of studies now that are linking the status of the gut microbiota with heart disease, and those are all likely mechanisms. Any kind of chronic infection, chronic viral or bacterial infection could potentially contribute to that. There are a lot of studies linking those things to increased risk of heart disease, things like H. pylori, the bacterium that causes ulcers, for example. So all the stuff that we generally talk about in terms of doing a thorough functional medicine type of workup are crucial. And then on the lipid front, you want to be looking at the NMR, LP-PLA2, which is different than lipoprotein little a. It's a little confusing. That one's sometimes referred to as plaque, PLAC. That's a specific marker for cardiovascular inflammation. It's even more specific. It's CRP, or C-reactive protein, is a marker for systemic inflammation throughout the body, whereas plaque, or PLAC, LP-PLA2, they're the same thing. That's more of a marker for inflammation within the cardiovascular system, so that can be helpful. And then, doing something like the calcium score, which looks at the actual state of your arteries. Like if you have calcification in your arteries, that's thought to be more predictive of future heart disease risk than any of the lipid markers. So, for example, you could have low or normal cholesterol, LPA, and if you have high calcium score, you're going to be at significant risk for future heart attack. Whereas if you have even high cholesterol or lipids and a normal calcium score, you're probably not going to be at significantly increased risk of a heart attack. So as I've said a few times in this show, you have to look at all of these different variables to determine your overall risk profile. Remember not just to treat a particular marker and worry too much about one particular marker, and look at the whole overall picture, because we know that over 90% of people who have high cholesterol and go on to have a heart attack have another major risk factor, like high blood pressure, smoking cigarettes, or something like that. So that tells us that high cholesterol alone and altered lipids alone are generally not, in most cases, not enough to cause a heart
Chris,
attack.
all that stuff sounds great. Just playing devil's advocate here, but that's just so much time, effort, money, all these resources to get all that test done. What's really wrong with a simple copay for a statin and a baby aspirin for the next 40 years?
Well, if you look at how many people take those, you might conclude that there isn't much wrong with that, and how often they're prescribed. And like as I've said before, there could be a time and a place for statins and baby aspirin, but I think the general principle of functional medicine is to address the underlying cause of a problem, because that leads to more lasting and effective healing with fewer side effects and complications and risks. And my goal is always to create the best to use. I often tell my patients I use whatever works and causes the least amount of harm. So if I can accomplish preventing a disease or treating a disease by using dietary and lifestyle interventions to the same degree or a greater degree than the results that I would get with using a drug that has, potentially serious and life-changing side effects, then I'm definitely going to choose the former. And the patients that I tend to work with understand that and want that too. And if somebody doesn't understand that and want that, there really isn't that much that I can do, Steve. It's more, if someone's can't be bothered to do those things, then they probably will end up taking a statin and taking baby aspirin, and there's little that I can do about it.
Yeah, I just want to throw that out there, because there are side effects and there are negatives to taking those too, because those seem so much simpler. And yet, another way to look at this, based on another alternative to what Chris just said, would be that, at 44, you got a lot of life ahead of you. Anybody, it doesn't matter your age, but these are signals that something isn't potentially quite right in your body. And maybe a statin and a baby aspirin don't cause or help avoid heart disease for a little while, but then maybe some other really serious health complication pops up in a few years. And so I think there's pivotal decisions, it seems like, when I talk with people throughout their life, where they're trying to get rid of a health issue, and sometimes they choose the simpler route because it seems so painful to go down the deeper route to fix things. And then everybody that I know, and myself included, know people who were just quote unquote healthy, and then they were gone the next day for a various number of reasons.
Yeah, and the thing about functional medicine, which I know we've discussed before, it definitely is more expensive up front, but I would argue that it's far, far cheaper down the line. And the principle is just different. The principle is you spend more money up front to do the proper testing and investigation to figure out what the underlying cause of the problem is, and to address it then, which will save you enormous amounts of money, time, and grief later on. Because if you are able to prevent, for example, a heart attack or type 2 diabetes or an autoimmune disease by adjusting your diet and doing testing to identify SIBO and other gut issues and treating those, and doing other kinds of testing that we do in functional medicine, and you prevent a disease like type 2 diabetes, you're gonna save unbelievable amounts of money and time and suffering from doing that. And unfortunately, I think it's partly human nature and it's partly our culture in the US. We don't tend to think ahead like that. We're mostly focused on what's right in front of us, and I think there are some evolutionary reasons for that. That's how we survived in part, and while we did have some capacity to think further into the future, it's much more difficult for humans generally to respond to a threat that is something that could possibly happen later on than it is for us to respond to something that is like right there in front of our face. And that's the big challenge, I think, for everybody when it comes to preventative medicine is, we need to be taking steps now to head off things that could potentially happen in the future. And it's difficult sometimes, as you pointed out, Steve, for people to make that investment of time and money and energy in the present for something that may or may not happen in the future. But that's exactly what's necessary if we want to stay healthy and prevent these diseases. So hope that was helpful, Isabel, and everybody else who is listening. And again, keep the questions coming in. And I just want to make another announcement, because I think this show's coming out somewhere towards the end of December, and there's something else happening at the end of December, which is my book, Your Personal Paleo Code, is being published in paperback, and it's being published with a different title. It's called The Paleo Cure. Got a different cover and everything. Sexy. It looks different. I like the new cover a lot, and I like the title too. It's more of a reflection of what we were trying to accomplish with the book in the first place, and so I just want to let everybody know that. So you're, first of all, so you're not confused and think that I'm publishing a new book that I haven't told you anything about. And number two, if you haven't picked up the book yet, while it was in hardcover, you have a chance to do that in softcover now. Obviously, it'll be cheaper. It's available on Amazon, Barnes & Noble, all the typical places that you would expect it to be.
Did you make any updates or any revisions?
And no updates or revisions. I think the book is, I don't really feel like it needed that. It's still all very current, and my whole purpose in writing that book was to have one place where I had all of my basic philosophy and approach on diet and lifestyle in one location. Because having a blog with tons of articles is great, but it's not the most user-friendly way to find, if I just want to tell somebody, hey, this is what you need to know about diet and lifestyle, and then send them an email with like 1,500 links to post, that's not very useful. But one book is helpful. So that's what it is, and it's a great resource, and especially after the holidays, if you're looking to jump back into on the wagon and you want something to help you do that, check it out, The Paleo Cure. If you search for that in Amazon, I think right now the hardcover will come up, but as soon as the book is published on December 30th, it will switch
congrats
over.
on pulling that off, Chris. I know it was a big project, and obviously if a listener hasn't picked up this book, or you're looking for a stocking stuffer, grab it and put it in the stocking stuffer. Try to spread this message out there.
Thanks, everyone.
Yeah,
Keep the questions
this
coming,
podcast,
and have a very happy holiday.
Yeah, this podcast is created by you and for you, so keep your podcast questions coming. KrisKresser.com/podcast question. That was a little wrong earlier in the episode. So podcast question is where you can go to submit. And in between episodes, if you're looking for new updates, like Chris was actually just posting some fascinating new gut microbiome research on Facebook. If you missed that, it's because you're not following him. So go to facebook.com/Kris Kresser LAC and twitter.com/Kris Kresser. Happy holidays, and thanks for listening.